Now may I request Professor Ruchi GOEL. She is from Delhi and professor at Maulana Azad. She has left now and into private practice. Everybody is coming to private practice these days. Shama, that is, yours is the next number.
No. I'm working somewhere. So, good morning, everyone, and a nice Sunday morning to all. So, I'll just, Dr. Kamaljeet has very kindly invited me to this talk, and I'll just go about how, when you get a case of glaucoma with cataract, which I think we keep getting day in and day out, what are the different approaches that need to be done? I'll touch upon the management in the sense the planning part and the surgical part. So, whenever a patient is coming to you, one thing is you need to see how well the glaucoma is controlled. क्या हुआ? चेहरा नहीं दिख रहा. So, okay, now I think people can see me well. So, how well the glaucoma is controlled? So, preoperatively must have a very good evaluation of the optic disc, the intraocular pressures, and if you feel that there is some kind of cupping and you feel that it is a suspect, please do your pre-op investigations prior to cataract surgery, because you may end up giving poor results and the patient will be after your life after the surgery that why have I not regained vision. So document. An OCT RNFL is a very simple test which can just document that yes, there is some kind of nerve fiber loss. Of course there would be cases where with advanced glaucoma where you cannot get a OCT RNFL also. Then the other thing is you have to decide whether the patient is going to be controlled just by my cataract surgery, because we all know that angle closure glaucoma, now the standard treatment, in fact what is happening is if the patient is predisposed to an angle closure and you do remove the cataract, many times these patients would have will reach the target pressure. So again you need to decide whether you do a cataract surgery alone or you combine it with a combined surgery. Now the next question is whether you are going to do an MIGS, minimally invasive cataract glaucoma surgeries, or you want to go for traditional trabeculectomies, or sometimes you maybe even need to do valves. Now I'll just push out the valves out of the system, because here we are all supposed to be dealing with day-to-day cases. So let's say MIGS. MIGS, yes, it can be done before you go in and construct your tunnel. You finished your minimally invasive glaucoma surgeries. It's a very easy procedure, but remember, many of these patients after doing a minimally invasive glaucoma surgery, they may have a little bit of post-op hyphema. Now cataract patients, they are so tuned that they come and say ki agle din why are we not 6/6 or 6/9. So those kind of things you have to discuss and plan before you go in for these kind of surgeries. Now whether to do trab or not. So if you think that your target pressure cannot be achieved, let's say, when I mean target pressure, let's say if it is about 0.7, 0.8 cupping and you're doing just a cataract surgery, you know that your target pressure is not going to be achieved just simply by doing a cataract surgery. So there you can, if the patient is going to be a compliant patient and you think he will take the post-operative anti-glaucoma drugs, you can simply add anti-glaucoma drugs. If not, then especially rural areas, the patient just don't put any drops. So there it is better to do a combined surgery. Now these patients, the problems that can be, again you have to divide whether it's again primary or a secondary angle closure or a primary open or secondary open. It's a very vast range of classifications, but as it is, these patients may have, as I said, there could be small pupils, previous attacks of glaucoma may have occurred. The patients may have floppy iris, they may have a shallow AC, there may be presence of pre-existing synecdoche, there may be presence of pre-existing trab. So most of us like to do a superior SICS, and there you need to shift your site to temporal SICS. Also remember that whenever you're doing a trabeculectomy combined with it, you don't want to injure the conjunctiva. So what you need to do is do minimal dissection of the conjunctiva, leave the conjunctiva as virgin as possible so that you don't have a post-operative fibrosis, because that may lead to failure of your trabeculectomy. So let us see, this is one of the, a very good investigative tool which has come into the system now. I'm not saying that you have to do an anterior segment OCT in all patients, But if you have this, you can always document and make the patient understand. Just look at this. It gives a very clear picture that this patient, you can see there is the lens thickness increase, and the lens is actually pushing the iris and decreasing the opening of this angle. So you can simply explain to the patient that maybe just taking out this cataract, you will be all right after the, the pressures are going to be controlled. Now, so I've already told you, and of course lens-induced glaucomas where you need to go in for these surgeries. When I say lens-induced glaucomas, maybe let's say about 2 weeks the patient has already been into attack and has already developed synecdoche. There you need to do a combined surgery. So let's have a look at the videos now. So this is how I do a SICS. So this is a frown incision, and you can see I am creating a small block here. So this is a square which is created right in the center. And remember, my incision, the external incision is about 1.5 to 2 millimeter from the limbus. My internal dissection would be again 2 millimeter into the limbus. This is the side pocket dissection, which is extremely important. And this is the Blumenthal technique which is being demonstrated. You can use any technique of SSCS, doesn't matter really. A rhexis of course has to be perfect, because remember, whenever you're doing a combined surgery, your IOL has to be in the bag. If it is not in the bag, you will have problems. So always IOL into the bag. This is hydrodissection. The nucleus is prolapsed into the bag. Again, there would be patients with very shallow ACs where you need to inject lot of viscoelastic, because otherwise you may end up injuring the endothelium. So this is the now remember, now you have to do a very good wash. And what I do is that, suppose you are not able to, you have a very floppy iris. Many of these patients are going to have a floppy iris. So what I do is simply put a suture for a while, let the chamber become stable. I use my band. You can use your Simcoe, but you can bimanual is a very good technique to give a good cortical aspiration. Put in the IOL in the back. Now this is how you create a sclerostomy, and this is the sclerostomy being created, and I use a MVR blade, and then I cut a block, and the interior part I just leave intact, because that will help in preventing the collapse of the chamber, and also it will help in preventing the against the wound drift. And after that I simply close the conjunctiva with the sutures. So this is a pre-existing trabeculectomy bleb, and here instead of you see the bleb is located superiorly, so I have made a temporal incision now. So this is a temporal incision, and here you can see minimally dissecting the conjunctiva so that you do not injure the bleb at present in the superior location. So once you enter, now remember this is a already pre-existing bleb. So what is going to happen is that there will be a lot of hypotony, and there would be presence of some synecdoche because of this bleb. So here maybe the anterior chamber maintainer, the pressure created by it may not be enough to push the nucleus out. So again the chamber is shallow, so a lot of viscoelastic, and now I've used two techniques. You see I've used a microvectors to pull the nucleus out. I've used the anterior chamber maintainer to keep my chamber deep all through, and I've also used put a suture at the end so that I don't have a leaky bleb. Now I think, sir, I can stop here, no problem. So the take home message is that these patients need to be, before you start your surgery, ensure you don't drive very high pressures when you just start your case. So if the pressures are high, you can give a Manadol, give a massage. No topical surgeries, combined surgeries are not topical surgeries, they have to be under a block. And suppose the patient has a cupping of 0.9, advanced cuppings, do not suddenly decompress, because that can cause wipeout. So slow decompression, put your MVR, slowly release vacuous, do a slow decompression. If your chambers are shallow, use high molecular weight viscoelastics so that you are able to protect the endothelium. Always put the IOL in the back, that's of paramount importance when you're doing a combined surgery. Do a good tight conjunctival closure so that you have a good bleb. You can use MMC simultaneously. MMC, I like to use this. I like to use it for 3 minutes, the 4% one. And post-operatively, now there is a fashion of not giving any cycloplegics, but any traps, please ensure that you have your pupil dilated and you have cycloplegia. That's extremely important for a good functioning bleb post-operatively. Thank you so much.